Next up, we're going to have Steve Gumbley is our next speaker, and he's actually going to be talking about the recovery-oriented system of care and outreach. Now, Steve began working in the human services in 1968 and has been specializing in education, prevention, treatment, and recovery of substance use disorders since 1988. He's a master's level licensed clinician and has served as clinical and programmatic administrator of a wide range of treatment programs. He's also presently the director of the Addiction Technology Transfer Center of New England at Brown University. So, Steve, yours.
Good morning.
Good morning.
I'm Steve Gumbley, and one of the important things I want to tell you today is that I am a person in long-term recovery from addiction. For me, that means I haven't been under the onus of alcohol or other drugs for 25 years, as a result of which my life has done a 180-degree turn, and I've gone from a person who was a taker and a needer, someone who had an overwhelming sense of uselessness and hopelessness, to a man of meaning today. And I share that with you in the hopes that by disclosing, by being a face and a voice of recovery, I can help change how other people see recovery and be part of the movement that creates new opportunities for those of us who are in or who need recovery. I want to thank Ryan and the staff at the Dania Institute for inviting me today. This is probably my fourth or fifth opportunity to speak at the Keeping It Real conference, and I look forward to that every year. You'll notice as I go through that some of the slides are not in the same order that you had them. Usually on the morning of a presentation, I get up early and review the slides and decide that things need to be in the new order. So I think most of them are there. A few may have been moved around. And I had a chance to speak about this issue last year. If any of you were here, and I think I recognize some faces, I hope that it's not exactly the same, that I've done some thinking and changing about this issue since a year ago. In following up on what Ron was saying, healthcare reform creates for us a recovery environment. So when we talk about outreach in a recovery environment, we're looking at this because healthcare is moving us towards that environment, and we need to understand our role in that process. In talking about health homes, they focus on prevention and chronic disease. We deal with chronic disease. And I'll talk a little bit about prevention today and how outreach attaches itself to concepts of prevention. Ron also mentioned that we're moving chronic care upstream. We work in a chronic care environment. Even though our approach is often acute, we work in small focused spurts of treatment. We really need to be moving towards a more chronic understanding of substance use disorder and the illnesses that are often associated with it. I want to begin by quoting Bill White. Bill is a researcher, writer, thinker about all things recovery. And he says this: folk wisdom says that recovery comes only when we hit our personal bottom. But recovery did not come to some of us in this room by hitting bottom. Some of us lived on the bottom, and recovery remained a stranger. Some of us were drowning in pain, had lost everything but our lives to addiction, and recovery still did not come. When it finally arrived, it wasn't forced on us, and we didn't initially choose it. We caught recovery in spite of ourselves. Some of us did not leave the streets to find recovery. Recovery came to the streets and found us. And it did so through workers, outreach workers, walking those streets, and they put a face and a voice to recovery. They told us that recovery was possible, and they offered their stories as living proof of that proposition. And they told us that they would walk with us on the road to recovery. The whole point of this is that recovery is contagious. It's like an infection. It gets spread by recovery carriers. We are recovery carriers. The only way recovery starts is through interpersonal relationships. It is socially transmitted. We are carriers of recovery, and we need to spread it around. We've been talking about contagion for a long time, and now we need to turn it on its head. A viable goal of our community, alcohol and other drug-related community intervention strategies, is to shorten addiction careers and lengthen, extend recovery careers. That's our job in outreach. So, what is this recovery thing that we're talking about? SAMHSA has put out a definition. SAMHSA says that recovery is a process of change whereby individuals, also communities and families, work to improve their own health and wellness and to live a meaningful life in the community of their choice while striving to achieve their full potential. If you look at some of the other definitions that have been created that talk about recovery, there are generally three elements to those. The first is reduction or elimination of symptoms. The second is an increase in internal wellness. I feel better about myself, self-actualization. And the third is community connectedness, what one group actually called citizenship, re-engaging fully in my community as a person in recovery. I pay taxes, I vote, I give money to recovery causes. I'm a full citizen in recovery. SAMHSA has also given us some principles to think about in terms of recovery, and Ron actually talked about some of these as a part of the healthcare reform. So when we talk about recovery, and I'll get into most of these a little bit more as we go along, it's driven by the person who is seeking or in recovery. It occurs in many different ways. It is holistic. We think about Maslow's hierarchy. Fundamental basis of that is breathing, food, water, sex, sleep, the basics. Okay? So when someone moves towards wellness, it starts with achieving and satisfying these basics. It's supported by our peers and through relationships. We'll certainly talk a lot more about that. It is influenced by culture, addresses whatever trauma exists for the person, involves families, communities, the whole spectrum of those available to us. It is based on respect, and it emerges from hope. Ron talked about that, hope. So when we talk about ourselves as recovery carriers, we are carriers of hope. Carriers that change is possible. Carriers that you can change. So it emerges from a hope that we carry with us. SAMHSA has also identified some domains, and I think that this these domains really address those three areas that I was just talking about. So health, personal health, home, purposefulness. Purposefulness is that internal sense of self, that I go from a life of, I sat in the chair, my last night of drinking. I started about 4 o'clock in the afternoon and gone out to dinner, socially drinking. And I came home and I was sitting by myself in a chair, and I think the technical term is shit-faced, and sitting there all by myself, overwhelmed with depression. I'd been drinking for 22 years, and alcohol had done what alcohol does. It acted as a depressant. And I was drowning in hopelessness and helplessness and a sense of uselessness and meaninglessness. And I wanted to kill myself. And I used to say that that was because I didn't want to wake up to another day of my life. But I've come to realize that I wanted to kill myself because I thought that waking up to another day of my life wouldn't make any difference to me or to anybody else. And so what changed for me in recovery most fundamentally is this sense of purpose, this sense of meaningfulness in my life. And I think that's a large part of what we need to carry to people, that lives can have meaning. Your life can have meaning. And the fourth domain is community. Relating to those around us, bringing all of the social networks that we have to bear, creating those social networks in order to support our long-term recovery. Bill White talks about a number of stages in this process. So we talk about recovery as process, okay? It is not an event. It is a process. It doesn't come all at once. So Bill identifies a number of stages. The first is priming, this opening the doorway. Initiation, sort of beginning to create this strategy of how am I going to change? Maintenance, what are the long-term supports that I have to maintain the recovery that I have and to build on it? And finally, what he calls termination, which is the sustaining of recovery long-term. Ron talked about this, about the continuum of health, moving from less healthy to more healthy. And so what Bill has done is laid out a process for that. And again, it does not come all at once. I think that's really important for us to keep in mind, that very few people make that change and turn around just like that. So recovery-oriented systems of care, we think about this, we talk about this a lot. A recovery-oriented system of care is a systematic collaboration that promotes and sustains recovery. It is systematic, system-wide, and it involves collaboration among those systems to address the needs of the individual. So these systems and this movement involves supporting the many pathways to recovery. I'll talk a little bit more about that. It is multidimensional and integrated, so the services don't fight with one another. We don't put up barriers to housing when people come out of treatment. We don't put up barriers to employment for people who have been in prison and need to find work in order to sustain their lives and their recoveries. It's designed to focus on the chronic nature of the illnesses that we're talking about. Our treatment system now is acutely focused. Come in for 3 days, 5 days, whatever length of time, we'll fix you and send you on your way. That's not how it works, and we all know that. It provides a continuum of care, focusing on folks where they're at in this process of need, of moving from less healthy to more healthy. It is driven by the patient, him or herself, and the strengths that that person has. We want to be asking what's right with you, not what's wrong with you. We recognize that treatment is an essential springboard for recovery for some people. Not everyone needs treatment in order to find recovery. Now, many of the folks that we work with do. They have more complex issues. They have co-occurring physical and mental illnesses. So they may need professional involvement, but we cannot draw a complete picture of folks who need recovery from the profile of folks that we work with. Recovery is vested in the community. I'm going to talk more about that. And it always includes the voices and experiences of recovering individuals and their families. Nothing about us without us. Don't have conversations. Don't make plans without us sitting at the table as part of the conversation. And I say to those in recovery, the other side of that, by our silence, we let other people define us. We need to be willing and able, as people in recovery, to speak up and speak out about our needs. And if we don't, we can't blame anybody but ourselves. Policymakers, funders, lawmakers, they are working with their best thinking and ignorance. They don't know until we tell them. So I'd like to ask, are there people in this room who are in recovery and want to share that with us? Just put your hand up if you will. Okay. I challenge you, please, if you don't already, think about new ways to be a face and a voice of recovery. In all of the settings that you're in, with your peers, your professional peers, speak out and say, this is what recovery looks like. I'm one example, so that people know. So, community, not treatment, is the ultimate healing agent. There's a growing recognition that recovery initiation, that first piece that we talked about, in institutional settings does not assure sustained recovery maintenance. Once a person goes out into the community, if we have someone in a treatment environment and move that person out into the community, to the very community that they were in before they came in treatment with the same strengths and pressures, chances are that recovery is not going to be sustained. The community is the soil in which such problems grow or fail to grow, and in which resolutions to such problems thrive or fail to thrive over time. So, how is outreach a part of recovery? Outreach, I'll define here as an extension of professional addiction treatment services in the life of the community, supporting clients in their natural environments before and after treatment. Through this process, this outreach process, we as addiction professionals extend core treatment out into the community, beyond the institution, to bring it to folks who haven't seen it or don't know they can become part of it. Outreach services move from the priming that we talked about and recovery initiation through recovery sustaining, stabilization, and maintenance. So, for instance, we can talk about assertive street outreach and institutional engagement, reaching out to crisis centers, jails, homeless shelters, hospitals, and to capitalize on the developmental windows of opportunity that exist within the addiction careers that folks have. We can do it by delivering services in non-stigmatized, natural environments, and by maintaining assertive contact with folks. So in thinking about this, this is one of the new slides. Community is where my addiction is active, and community is where I maintain my recovery. So there are some significant influences, can be some significant influences on that. Prevention activities at one end, and recovery support services at the other. And I think that outreach activities cover both. They move from prevention, trying to keep addiction and its co-occurring illnesses from happening in the first place, to providing support services in place in the community for those who need them. So, we want to think about outreach as this set of strategic initiatives that are targeted. They're targeted to people who have been traditionally underserved, who may not know that services are available, who believe that they do not need our services, and that may be because they don't think the kind of thing that we offer applies to them, and we may not be offering them what they need. It may be that they have no hope. It may be that they don't believe they can change. And maybe they don't think that they qualify, and maybe they don't qualify for the services that we offer. So we target them, and we do assertive outreach to change those conditions. We are change agents, recovery carriers, hope builders, change agents. We bring the desirability and process the possibility of change to the folks we serve. Now, there are a lot of folks in this room who didn't raise their hand, who are not in recovery. What about you? How can you be a recovery carrier? I do some college teaching in psych around addiction issues, and very often students will say, well, who makes the better counselor? The person in recovery or the person who's professionally trained? Sound familiar? My answer is, if I were hiring, I'd say both. Okay? But the short and long of it is, everyone has experienced a change process. Every one of us. And part of the work that we need to do is to reach inside of ourselves and come to understand what that change process is and how it happened for us. To understand that change process. Just because it doesn't happen to be in the addiction or mental illness realm doesn't invalidate it. Okay? We are change agents because we are changers. We have opened ourselves up to the possibility and the actuality of change. So if you haven't thought about that, I would encourage you to think about what is the significant change process or processes that I've been through. What happened to me? How did it start? How comfortable or uncomfortable was it? What resources did I use? How did I reach out to folks? How did I push folks away? Understand the process as a way of being empathetic and understanding for those that we're working with. So, we're here to talk about the competencies today, these outreach competencies. And these are there. Understanding outreach itself and outreach in a scientific context. Understanding chemical dependency. Understanding disease and wellness in the context of drug use. Engagement, intervention, client support, and supporting ourselves. Well, you can see that a number of these probably fit into this discussion about addiction recovery and co-occurring illnesses. So we'll talk about some of those. The first one, understanding disease and wellness. Again, we want to look at what makes people well, not what's kept them shackled to a life of illness and social problems that they don't want. That's what we tend to look at, the pathology, not the wellness. It's time for us to begin to understand wellness and health in all their complexities. And as Ron pointed out, not have an end product over here. Okay, when you get there, you'll be healthy. You'll be in recovery. You know that we've done that for years because we've had the gold standard for recovery. What is it? Abstinence. Permanent, lifelong abstinence. Yes? Is that the only marker for health and wellness? No. No. So we need to understand. One of our competencies is to understand wellness and to speak about wellness. That's on us. Engagement. It's probably the most important outreach competency that relates to the recovery environment. So we'll talk about some parts of this. And in the competencies themselves, there are subgroups, recruitment strategies, cultural sensitivity, safety and awareness of environment, and effective communication. And just to let you know, I've had some discussion with the Danya staff. We're going to take a look at this language and the subparts of this and take a look and see if we can connect the wording, the language, the concept much more with this recovery process, because although I think all of the elements are here, they're not laid out in a way that really connects them to recovery concepts. So, through the outreach process, ourselves as professionals, also peers, people who have graduated from programs who are in recovery, extend core treatment and recovery services beyond the walls of the institutions we work for and take it out into the community. And again, they move across that spectrum from pre-recovery, recovery initiation, stabilization, and long-term maintenance. Engagement. Recovery-focused treatment, it's like finding property. You know, location, location, location. It's engagement, engagement, engagement. Did you get that? Engagement, engagement, engagement. It's reaching out, touching, and motivating each client on his or her individual basis. Finding out what might help them to change and connecting with them. And understanding that each time we engage with a client, we have an opportunity to build the motivation. There are many pathways to recovery. Recovery is not monolithic. So I don't know if you've heard about an organization called Faces and Voices of Recovery. We're a national organization that organizes and mobilizes people in recovery to change the environment for people in recovery. And I have the blessing of being on the board of that. And when I joined, they asked me to do a little blurb and a bio that could go on the website. And so I happen to, I come from a family that has been for generations overcome by addiction. My dad had alcoholism. His father had alcoholism. Both of his grandmothers, my great-grandmothers, had alcoholism listed as the cause of death. And that's just one side of the family. So in this little blurb, I wanted to talk about family wellness, and I happened to mention that my dad was sober for many years before he died. And someone at the Faces and Voices office crossed out sober and put recovery. My dad was in recovery for many years. And I said, well, no, he wasn't. He didn't do AA. His recovery didn't look like mine, so I didn't label it recovery. But it was his recovery. He did it the way that it worked for him. And we need always to honor the many pathways that folks find wellness, move the ways that folks move from not so healthy to more healthy. We need to honor those, not just respect. We need to use those and honor those. These pathways to recovery are highly personal. They're about my identity as a person. They may involve pharmacological treatment, medication-supported recovery. You know what that means? That means methadone, buprenorphine, other medications that support recovery, psychotropic medications. People are not in recovery because they're on methadone. All right? People are not in recovery. They're not still using because they're on a buprenorphine regimen. They're in recovery and they're taking medications to support their recovery. I take 2 medications a day, antidepressants, to support my recovery. And believe me, you wouldn't like me standing up here if I weren't on those meds. They're part of my holistic recovery. For some, and I think this is really important for us to keep in mind, recovery involves neither treatment nor involvement in mutual aid groups, what we typically think of as 12-step recovery support groups. That doesn't have to be the way to recovery. I'm not saying that folks don't need community support. I'm saying it doesn't have to be that pathway. There are folks who have natural recovery. Folks who do not need any professional intervention in order to find wellness. The wellness that works for them. They don't need us. Think about the number, one of the hardest drugs to move towards abstinence with is nicotine. Think about the number of people who do not have a professional intervention in order to move to nicotine abstinence. Think about it. They don't need us. And if that group exists with a very difficult addictive drug, then there are clearly folks who move towards wellness, towards health, with other less addictive substances. So, when we talk about engagement, we want to say to expect resistance. Expect that folks have experiences that do not support our point of view. They have their experiences that support their points of view. Respect that. Build on it. Respect the point of view. First of all, listen and find out what the point of view is. And then respect it. If we can, tell bits of our own story, but this isn't about us. We only use our stories as examples to spread the hope. And we try to empower people. You know this. Many of the folks that we work with believe that they can't change or that they've tried and they've failed. How often do we use that word in treatment? You failed. You failed. We have got to overcome and throw that language away. Change may not happen exactly as someone wants, to the extent that someone wants, at a particular time. That does not constitute failure. And we need to keep reminding folks of that. Okay? We need to empower. Change is possible. Change is here. Let me help. Be tenacious. Put up with the bull. Put up with it. Work with it. Don't resist. Move with the change. Help folks problem solve, and most of all, be real. Don't use platitudes. Be real. So, self-directed and empowering. Recovery is fundamentally a self-directed process. I am in charge of my recovery. So I went to outpatient treatment when I started my recovery. And I went in 1 week, the first week, and had a long assessment and answered all these questions. And the second week I went in and sat down with the therapist and said, okay, what do we do now? And she said, well, what do you want to work on? Why are you asking me that? You did the assessment last week. You know what's wrong with me. Fix it. No. This is your recovery. You've got to, no, you're the professional. Tell me how to fix myself. And we had an argument about who was in charge of my recovery. She won. But I think that's the message that we give to folks. It's the message that we believe. I'm the professional. Listen to me. I'll fix you. Our system will fix you. The person in recovery is the agent of recovery. What we need to do is give people the power, the knowledge, the skills, the tools to make the change and move towards that highest level of autonomy, which may not be abstinence. So I was in recovery from alcoholism, the first 8 years of which I continued to use nicotine addictively. No one thought that I wasn't in recovery. But if I'd been using marijuana, you think it would have been a different story? And suppose I said, well, alcohol was a big problem. Marijuana, I used to only smoke it occasionally. It wasn't a problem for me. I don't think it's something I have to give up. People would have said, you've got to be abstinent, and forgotten about the nicotine. Okay? So we need to think about recovery in a broader sense and let the person in recovery define what recovery is for her or him. This assertive outreach begins with a relentless initial engagement process and a dogged willingness. Boy, I like that term. A dogged willingness. Okay? To press for recovery. So there are some things that we can do to promote this engagement process. Engagement. Assertive street outreach, pre-treatment peer support groups. think you might have a problem, you want to come and talk about it, you don't have to say, hey, I'm Steve, I'm an alcoholic. You could just say, hey, I got a couple of questions I came here to talk about or listen to. Offer peer mentors. Develop recovery support centers. That's one of the big things that's going on now. In Providence, Rhode Island, which is where I'm from, just outside the city, we established the first recovery support center in the state in December. By the first week of September, they had already had 40,000 visits. Okay? In a little over 6 months. 40,000 visits. You think that speaks to a need for recovery centers? Instill hope, be charismatic, connect with people on an ongoing basis in many different ways, and establish relationships with natural supports, the people around the person that you're trying to reach out to. Patience, love, respect, empowerment, persistence. Key elements, key skills for an outreach worker. Patience, love, respect, empowerment, and persistence. Those are our goals as outreach workers, as agents of change, as recovery carriers. There are things that may get in the way, obviously. They do get in the way. Social stigma, not being able to overcome my own sense of being overwhelmed by this disease, denial, distrust, hostility, sabotage. A lot of these also happen for folks who have been in the system round and round and round. Okay? I begin to build my defense mechanism. Okay? I know how to tell my story because I've sat down and told 22 caseworkers the same friggin' answers. I know how to tell my story. But is it the truth? Is it the truth? Has that person created an environment in which I can tell the truth or help me discover my truth? Because I might believe my own BS. Practical issues get in the way. Transportation. Okay, your appointment is for tomorrow afternoon at 2:15. Be on time. I don't have a car. I've got kids to take care of. Outreach means going out to others to help overcome so many of these obstacles to engagement. Intervention is the next competency. Actively working with the client to reduce the harmful effects of the client's behaviors. So there's this engagement period, this incubation, if you will, that we're responsible to start. To incubate the concepts of recovery, that recovery can happen. This is what it may look like. This is what you can do, beginning to build that plan. Incubate recovery. So I think that this is where outreach connects with prevention. Okay? Prevention, as you know, it's sort of over here. We have treatment. And we got prevention folks over here who think they don't fit into anything else. And I think that prevention is an essential part of recovery and that it connects through this outreach piece. Okay? So there are typically three levels of prevention that we talk about. So this, and I'll give you an example. If we were talking about LL Bean and the catalog, how many familiar with LL Bean? Get the catalog? Okay. So Universal, level 1, would be that LL Bean sends their catalog to everybody in the state of Maine. That's universal. Selective would be that they send their catalog to everybody who went to a state park last year camping. They did something that's connected to how LL Bean sees itself. It's a targeted group. Indicated means they send their catalog to everybody who bought at LL Bean last year. Okay? It's individual. So when we think about outreach, outreach really involves selective, but more so this indicated level of prevention. Looking at targeted folks. Okay? Looking at risk factors. Now these address both those who are in the groups, the indicated, and that those who actually show the risk factors would be folks who are indicated. But you know this list. Chronic home environments, where there's substance use disorders, mental illnesses, ineffective parenting, kids who, families who are engaged with child welfare, kids who have behavioral problems in school, academic problems in school, difficulty with peers, conflicts with peers, and how folks see the use of substances in their home, what they think is the norm. Okay? All of these are risk factors for folks and help us begin to target who is it that we're going to reach out to. Client support is another of the competencies. Facilitating the client's utilization of available support systems. Okay? Helping the client know what those supports are, know when they're available, how to get there, how to use them, what the expectations are when you get there, maybe going with the client the first time or two. Facilitating the client's utilization. You know, we talk a lot about referrals in our field. We do a terrible job. Well, actually, sometimes we don't really do the job. We hand someone a card and say, go see so-and-so. At best, we might say, I set up an appointment for you. But things get in the way. I was working on a grant proposal with a group, and we were talking about having peer escorts who went to your first appointment or two with you. Someone who's actually been to that place, is familiar with it. Going with you. Robust referrals. Robust. Okay? This is the continuing engagement. If we don't provide the service and we need someone to go to the transportation office to get bus discount cards, we may need to go with that person, not just give them the address. So that's what outreach, aggressive outreach, means. So our roles, and I've already talked about some of them: recovery carriers, change agents, hope givers, motivator, similar kind of thing, an advocate to speak for, problem solver, and that's not so much to solve for as solve with and teach how to solve, a confidant, a role model for change, nurturer when possible, cheerleader, confronter, lifestyle consultant, historian. I say to my clients a lot, part of my role is as your historian. I can remember where you were 3 months ago, what was going on. If you don't think you've changed, I know you've changed. These are all part of our roles. Recovery support services is an essential part of this providing client support. I've added these slides so you don't have these, but I could send them to Ryan. So recovery support services, they're non-clinical services that help remove those barriers and provide resources to this priming, initiating, and maintaining recovery. Very often peer support services. I'm coming to the end, I know. Only a couple more slides. So examples, one-on-one support, groups that provide support, various kinds of groups, educational, life skills, connecting with resources, that Maslow's hierarchy piece, skill development. We had at this recovery center in Rhode Island a Saturday where a number of lawyers volunteered to come in for a workshop one Saturday morning, because how many of our clients have legal issues around employment? You know, check the box that says, yes, I've been convicted. How do I deal with that? So providing these sorts of development. Recovery skills development, alternative activities, social activities that don't involve the use of alcohol or other drugs. And finally, teaching folks about leadership. It's part of this citizenship that I talked about early on. Recovery is vested in the community. Recovery is in the community where we live, work, and play, and maintain our long-term, our sustained recovery. So the recovery needs to contain the elements that support this maintenance of recovery. We need to have recovery supportive communities. That's it. I hope I've helped you think about this a little bit differently. Thank you. We are living in a recovery-focused environment. If we don't change our thinking, we'll be out of jobs, we'll be inessential. So, thank you very much. Ryan would like me to respond to any questions, comments, concerns. Someone's getting up.
Hi, how are you? I would like to know, and I want to thank you for breaking your anonymity, because you don't find many people doing such. I too am in recovery, celebrating 23 years as of July. Thank you, thank you. And I wanted to know, well, I'm working in the prison system, and I realize that there are some people who are in the prison who should be and should have went to treatment, and there are people who are in treatment that should have went to prison. I don't know if people understand what I'm saying. Like, the drug dealers know if I say I get high, I'm going to treatment. And the people who are stealing to support their 20-day habit of heroin are going directly to jail. But there's no treatment being done in prison, just them laying low until the such day of being released from treatment. I mean, from prison, and they go right back to where they know, and that's that 20 bag a day heroin habit, to start the cycle all over again. What I wanted to know is why aren't there any kind of assessment tools on the court level? And I'm not talking about drug court, because everyone does not go through drug court, where the judges, the prosecutor, and all these people know that this person actually do need treatment and not, you know, going directly to jail.
I don't know of any court-situated tools. Thank you, by the way, for sharing your own recovery. I don't know of any court-based assessments, but I know some correctional systems are and have initiated substance use disorder assessments when people come in. As they're not just looking at the exit and the reentry piece, but looking at the beginning when folks come in, lay out that process of reentry. But it's an area that needs a lot of work. One thing I will say, when I speak publicly about my recovery, I do so without identifying whether or not I'm in a 12-step program. Okay? So I don't, in that instance, I am not compelled to maintain any of the traditions of a 12-step program.
I'd just like to hear your thinking on this. In 1970, I was part of a group of people who opened a methadone treatment center in DC, and we were overrun by patients. Last year, probably more people were killed in Mexico over this drug traffic coming into the U.S. than have been killed in both Iraq and Afghanistan combined in 10 years. Last night I left here, I stopped at a service station to get some gas. And there were 3 to 4 young men in line in front of me, I thought, to pay for gas. But no, they were buying 1 cigar, 2 cigars each, and describing in detail the flavors that they want to held me up forever to get my gas, describing to the attendant who didn't handle English too well what they wanted in terms of these 1 little cigars. And I looked across in back, and they had all of these cigars lined up, all these boxes. Just what do you think?
Well, I think that we need to continue to have in this country a dialogue about good drugs, bad drugs, things like that. I mean, if you watch the evening news, 90% of the commercials are for various medications. And I think it's easy for folks to be very confused about what's okay. Not confused, not because it's not written in law, but confused attitudinally about what's okay and what's not okay. And we need to continue to talk about and think about this. This is part of prevention. And I'm not suggesting that we necessarily go back to something like prohibition, but we need to think about how are we going to strategize about the use of drugs in a medication-focused society. No simple answer.
Just a brief comment. My name is Jay Henderson. I'm a court assessor. We do the A505, 8507 assessment. It's a smart-driven assessment in Baltimore City at BCDC, where we evaluate the level of care and find a placement for clients in need of substance abuse treatment.
Thank you. Thank you for sharing.